Good day, everybody. So I'm Chamath again. Thank you for the kind introduction, Edmund, my very good colleague from WHO Primary Healthcare Young Leaders Network. Thanks for having me here. And I'm also privileged to co-facilitate this session with Dr. Yakubu, who is one of my lecturers from Lancaster University. So to start off with, I will introduce myself as a fellow person who is striving to develop palliative care in another developing country. So we might have certain things in common, and the context might be slightly different as well. So you would know the best how the Ghana health system is geared to provide palliative care and how things can be changed. So what I'm sharing here might be the things that can be universally applicable across countries who are striving to develop primary palliative care. So we will also learn what primary palliative care is. And the topic would be the community palliative care and the role of the registered community nurse in Ghana in delivering community palliative care. So what I hope to cover during this session would be what palliative care is and how big is its need globally, and whose job is palliative care. How do we work in a team to achieve good quality palliative care? How does generalist or primary palliative care compare with specialist palliative care? And where is the registered community nurse located within the health system? And the WHO has recommended to develop 4 main domains concomitantly if we are to develop primary palliative care within a nation. So we will also look at them in this session. And networking with the like-minded people. This is very important, and we will discuss how we can achieve this. Right, so moving on to what is palliative care. So you might have an understanding already. So we will just look at the term palliative or pallium. So pallium is to cloak. Palliar is to cloak. Cloak is to cover. This is an all-encompassing clinical discipline that aims to provide holistic care to the patients, placing the patient right at the heart of care. You try to provide comprehensive care around the patient, covering all aspects of care. So that is why it is called palliative care. And moving on to the definitions. So this is the most widely used definition by the World Health Organization. Even I do not, hope myself to remember this definition by heart, but each and every aspect of this definition needs to sink into your heart when you are providing palliative care. So palliative care is an approach that aims to improve the quality of life, even more than the quantity of life. You are aiming to improve the quality of life of patients and their families, not just the patients, involving their families here. So patients and families facing problems associated with life-threatening illness through prevention and relief of suffering by means of early identification, impeccable assessment and treatment of pain and other problems. So some people attribute that palliative care only deals with pain, but it deals principally with many different dimensions of pain or suffering. So that could be other physical problems, psychological, social, and spiritual problems. So that is why we are assuming an all-encompassing approach when we talk about palliative care. So the definition 2 is from the International Association for Hospice and Palliative Care. The only change I want you to notice here is that it is also incorporating the caregivers' welfare into this definition. So the caregivers could be informal caregivers, family caregivers, and you are also care providers. So the clinician's welfare is also included in this definition. Dealing with death, dying, and life-limiting illnesses can essentially push you towards a bit of burnout, compassion fatigue. So you might have to keep your emotions on the check, as well as have a very supportive network between your colleagues. You need to have each other's back. When somebody looks like that person is distressed, you could, reach out and help that person, and vice versa. So that is how the caregiver's welfare is also ensured in palliative care. Now, how necessary is palliative care? How big is the need? Then we have to look at the global leading causes of death. Because we are dealing with death and dying, the patients who are, imminently facing death, we need to know what are the leading causes of death. So if we are to look at the list, ischemic heart disease leading to heart failure, stroke, chronic obstructive pulmonary disease are the leading most causes of death. So these patients anticipate death in the forthcoming years, months, or days. So then they are benefiting from palliative care. And then you have lower respiratory tract infections. And even below that, you can see there is Alzheimer's disease and other forms of dementias, cancers, diabetes mellitus, which forms a significant, which causes a significant contribution to the suffering related to multimorbidity, which is another, collective condition that needs palliative care. So if you would see through this list, the road injuries, diarrheal diseases, and other infectious diseases are right at the bottom of as causes of death. They are right at the bottom. So the leading causes are life-limiting illnesses, essentially. So I've also talked about multimorbidity here. You have to read an article or two about multimorbidity, some systematic reviews on them. So that will give you a better idea about how serious is multimorbidity affecting the populations, and how palliative care would fit in the context of multimorbidity. And now, whose job is palliative care? Have you thought about this? I'm sure you have. And I'm doing this session for registered community nurses. That means that you are part of the team. You are a big part of this team. But essentially, through the models of palliative care delivery that has been studied worldwide, each and every model is based on one important fact, that it is only achievable through teamwork. You working with other clinical professionals and even other professionals and even communities, people, families in an efficient team to ensure that the patient receives good quality palliative care. So it is only achievable through teamwork. So palliative care is not just one person's job, it's everyone's job, essentially. And then if we are to look at the personnel who are involved in this team, the clinical professionals are usually associated with dealing with physical and psychological problems. So that's us. There is the nurses who provide care for the patients in the community, hospice or hospitals. So there are 3 different care settings. So you are community nurses, you are fitting there. And then there are other doctors. So general practitioner would be working alongside you in the community. In certain contexts, they are called the family physicians or primary care providers. So they form the community-based care team. And then there, in the hospital settings and hospice settings, there can be disease-specific specialists such as oncologists or cardiologists, pain specialists, psychiatrists, interventional radiologists, and even palliative physicians. So it is a huge team of doctors and nurses there. But are they all? No, there are more. So there are allied health professionals, such as physical therapists, such as physiotherapists, and then there are psychologists, psychotherapists, community pharmacists. So there are other allied health professionals. Is this all? No, the list continues. So alternative therapists are there. So art therapists, music therapists, relaxation and reflexology therapists, massage therapists, and all. And you have to bear in mind one particular thing. Although we are practicing allopathic medicine, some traditional forms of medicine, in our context, I can talk about Ayurvedic medicine, is quite acceptable by certain populations, even than allopathic forms of medicine. So you might have to work in liaison with these clinical professionals. And there are evidence-based alternative complementary therapies that can be efficiently amalgamated with the Western forms of therapies that we are dealing with. So we have to work in liaison with them, and the patient's satisfaction might be at the forefront of caregiving. So these are pretty much the clinical or physical forms of therapists that we are talking about, but beyond them, there are others who are essentially working in our team. So they are the family members, social workers, home carers, and community volunteers who provide social aspects of care. So they also work with us in providing holistic care. And then the spiritual aspects are dealt with by religious priests. But you also need to understand that spirituality is a concept that is quite overlapped with religious faiths, but is quite distinct from the religion. Certain people might have a broader understanding about many religious faiths and have an individual form of understanding about spirituality. So then we have, in certain settings, not obviously in Sri Lanka, there are multi-faith hospice chaplains, pastoral caregivers who do not, they are not working from the point of view that the patient would have subscribed to a particular religion or a faith, but they try to understand the form of spiritual understanding within the patient and try to reinforce it, which is more important. So we have to have a better understanding about spirituality and get these professionals help as necessary to help these patients. And then there are lawyers, clinical ethicists, sociologists who are also helping us in the team. They are not part of the routine team, but in specific centers, they are part of the team, and we can summon them whenever problems arise. So the lawyers may be involved with devising, formulating advanced care directives, or even putting up patients' last wills, and so on. And clinical ethicists can be involved when there are ethical disputes and all that. So now we know who are in our team, and we must know how do we work in an efficient team. So this is a very, big area if we need to understand in detail. But what I would say is that I can share you an article with you, a team approaches in palliative care that I, co-authored with one of the Lancaster University academics, Dr. Sean Hughes. So this is a review paper where we reviewed different models of teamwork that are proven to be effective in palliative care delivery. So we came up with 3 main models. One is multidisciplinary care, transdisciplinary care, and interdisciplinary care. Each of these keep the patient right at the center, and all the other health professionals and others they are working as a team around the patient to provide holistic care, not with the intention of not leaving any care gaps. So these, if you would see the circle around the patient in each model, so there can be there are gaps in certain models, but in this the interdisciplinary care model, the gaps are very much less. So that is what we hope to achieve in delivering palliative care. So that is so. I mean, I would share this article with Edmund so that in turn he could share it with you, and you can have a read around how it is like to work in each of these teams and what would best fit the context in Ghana, in the community setting mostly. And then, so we need to distinguish between what specialist palliative care is and then what generalist or primary palliative care is. So I was heartened to know that Ghana has a special training program for nurses, to specialize nurses in delivering palliative care, which is very good, which we don't have back home in Sri Lanka. So the specialists, however, are specialized in their discipline. So they have an in-depth knowledge about complex palliative care issues, how to deal with them, and all that. So that is where the specialized doctors and nurses would fall in. So they are mostly working in hospital settings, and they are very fewer in number. And then there are generalist palliative care providers who are also called primary palliative care providers. Well, that is you and me. So we are greater in number than the specialists. Our knowledge about clinical disciplines is broad. So as a general practitioner, I am not just dealing with palliative care, but I'm dealing with many other problems that the patients would have. So the same with a registered community nurse who has a knowledge of breadth, a broad knowledge, and also is knowledgeable about, you are knowledgeable about palliative care. Well, that is important. So palliative care is just one of your jobs, but that is also important. And our knowledge may be limited by its depth. So beyond a certain point, when the palliative issues are very complex, or if there are palliative care emergencies, we might have to refer these patients to the hospital settings, hospice settings. Otherwise, we must have a sound knowledge to manage the patients in the community settings through this generalist or the primary palliative care approach. So if I'm to give you a little bit of detail through the through a diagram, so we have, this is a rough, I think I've gotten it approximately right. The Ghana population is around 30.5 million. So that's at the base. And the specialists are at the apex of this pyramid. So they are very lesser in number. So specialists in palliative care. And in between are the generalists, that's you and me, as we talked about. And we are higher in number. And we are essentially the link between this 30.5 million population and the specialists. So the population immediately seeks help from us, and then if the need arises, we seek the help from the specialists. So I will also come to the point why generalists are better equipped to provide primary palliative care in the communities. So all these numbers, the population I have got is right, but the numbers are just rough figures. They are not the correct numbers in Ghana. I did not have access to those. So as generalists, what we try to achieve is universal health coverage in terms of palliative care, so that every person, every family, every community, in every nook and corner of your nation receives the basic palliative care that they need when they need it, right? So we are trying to provide palliative care assuming or believing that it is a human right than a very specialized form of a need, right? So that is our role here. Then settings where palliative care is provided, as you would know, there are hospital settings, hospice settings, and home and community-based settings. So either way, the registered community nurse is able to provide care in both community settings and hospice settings in general, right? Because you always liaise with the hospices which are located in your localities, even within the communities. So although these are the three main settings of palliative care provision, there are many other overlapping settings that are available in different countries, in different regions, based on the nature of their health systems. And this is a very important document, I would say. It is freely downloadable from the World Health Organization website. It is their publication entitled Integrating Palliative Care and Symptom Relief into Primary Health Care. So this is a guide for the planners, implementers, and managers, including the registered nurse, obviously, how primary palliative care can be established in your respective communities based on the resources you have and which resources you need to expand, and how to collaborate between other professionals and organizations. So this is a very important book. There are interrelated books that are associated with this publication as well. But this is a very important must-read, which is very short. You could just read it. And most importantly, there was a landmark event for palliative care providers and primary healthcare workers alike. That was in 2018 in the Global Conference on Primary Healthcare. The World Health Organization declared palliative care as one of the 5 components of primary healthcare. So that makes palliative care, the job of primary healthcare providers. That is us. So it is our job. So there were 4 other domains in primary healthcare, namely promotive care, preventive, curative, and rehabilitative care. And the new baby that just took birth is palliative care within the primary healthcare system. So this is the achievement that we got through the Astana Declaration on Primary Healthcare. So how well is the community nurse positioned to deliver palliative care? So why do you think? You already know this. So you know your patients, you know your communities, the societies, and you spend more time with these people, and you are very familiar with their ways of thinking, their health problems, their economic problems, their level of education, their faiths, religions, cultural subscriptions, their belief systems. You are very aware about these, so you are in a better position to understand and evaluate their problems and even resolve them. And beyond your best understanding about the people, you also know about the resources that are available in the community. So there can be clinical resources. Okay, there is a physiotherapist, and you can link this physiotherapist up with a lady who is diagnosed with chronic obstructive pulmonary disease, who would benefit from some postural drainage. So then you link up the physiotherapist with this patient. So you know the resources. And if there is a lack of resources, you also know that. So which is why you are well positioned for this primary palliative care task. And then, as I said earlier, you form the link between the broader population, your community, and the specialized palliative care services in the hospital and hospice settings. So you are the link between these the population and the institutions. So, as I said earlier, the WHO has recommended any nation to develop 4 main domains concomitantly if we are to develop primary palliative care. So they are the policies which integrate with the system, including the clinical system as well as the legal system. All these have to prescribe pretty much the same thing in terms of caring for these patients, formulation of advanced directives, which is another topic if we can have time to discuss that. So policies that integrate, and then education for all primary healthcare staff, a service structure that can provide from generalist to specialist palliative care, how these organizations integrate and how do they interact with each other, and then the availability of medicines. As you would know, the opioid medications that are used mostly to treat cancer-related pain are tightly regulated, but at the same time, we need to ensure that these medicines reach the people who need them when they need the medicine. So these are the 4 aspects that we need to strengthen right at the core. And it is very important that if we are developing from the scratch our palliative services, we can learn from our neighbors who have done well in terms of the African region. I have read and I have learned that Uganda, South Africa, and Kenya are doing very well in terms of palliative care services. So we can learn from them. And being a Sri Lankan clinician, I adapt so many things from India. The Kerala palliative care system is a known, well, widely accepted, cost-effective palliative care model. So we have so many things to adapt from them. So they have learned from their mistakes, and we can in turn learn from them rather than going through the same course of mistakes ourselves. So that saves time, and that cuts short your path towards the development of palliative care in your respective clinical setting. So then, beyond the regional, help from the fellow neighboring countries, we also have other international associations such as the World Hospice Palliative Care Alliance, International Association for Hospice Palliative Care. So these are international organizations dealing with palliative care. And then you have regional ones, the African Palliative Care Association, and 2 other organizations that I'm dealing with are Asia Pacific Hospice Palliative Care Network, where I belong, and I also work with the European Palliative Care Association. So there are so many. Even the USA and the region of the Americas, they have so many palliative care special interest groups, task force, and associations with whom you can form links so that you can work towards collective goals in the region, beyond the region, or globally, and also get their assistance in developing health systems, education in your respective countries. So in summary, palliative care is everyone's job, and you need to work in a collaborative manner through effective communication between other professionals who are involved. And registered community nurses' role is at the very heart of delivering primary community-based palliative care. So that will not only enhance the quality of life of patients, their families, but also entire societies, because they know they have a means of means to alleviate their suffering if they are faced with such terminal diagnosis. And a concomitant positive transformations in policy, education, service provision, and medication availability is warranted. So these have to be developed in a simultaneous manner. and lessons need to be learned from those who had learned the hard way. So that is your colleagues from the region and beyond. And if you have questions, you can pose it here. Thank you very much.